It is often assumed that wartime medical systems, even inside prisoner-of-war camps, functioned according to clear rules and established procedures. The common belief is that doctors, however limited their resources, followed manuals, regulations, and international conventions that told them what to do in nearly every situation. This assumption holds reasonably well when examining routine cases involving male prisoners suffering from malnutrition, injury, or disease. But there were moments during the Second World War when medical officers inside camps encountered situations that did not fit neatly within the rules they were expected to follow. When that happened, the limits of the system became visible. One such moment can be traced through camp records from the early 1940s, involving a female prisoner held in a military detention facility originally designed exclusively for men. She was not a senior officer, nor was she a public figure. Contemporary accounts identify her only by her role as a medical orderly attached to a frontline unit before capture. She arrived at the camp as part of a small group, processed through the same intake procedures used for thousands of male prisoners before her. According to the ledger, her name was entered without comment. The system registered her presence, but it did not truly know how to handle it. The medical framework of most prisoner-of-war camps during the Second World War was built around a predictable set of problems. Camp doctors expected injuries from combat, chronic malnutrition, frostbite, infectious diseases, and exhaustion caused by forced labor. Medical inspection routines, infirmary layouts, treatment schedules, and reporting forms were standardized accordingly. These procedures were shaped not only by medical practice, but by administrative efficiency. Doctors were required to examine large numbers of prisoners quickly, identify those unfit for labor, and return the rest to work details as soon as possible. Individual complexity was rarely encouraged. International law offered only partial guidance. The 1929 Geneva Convention required detaining powers to provide adequate medical care and to respect the health of prisoners. It did not, however, describe how camp medical services should address cases that fell outside the assumed norm of a male soldier's body and routine. In theory, medical officers were expected to apply professional judgment. In practice, they worked within rigid administrative constraints that discouraged deviation. When the female prisoner in question was examined during intake, the medical officer followed standard procedure. According to camp reports, she underwent a general physical inspection. Her weight was recorded, and she was classified as fit for light duties. No separate medical protocol existed for women, and none was requested at that stage. The camp infirmary had no specialized equipment, and the doctor, trained in military medicine, had limited experience treating women in a confined institutional setting. At that moment, the system appeared to function normally. The difficulty emerged later, when her condition began to deviate from what camp rules anticipated. Records suggest she reported recurring physical symptoms that could not be easily classified under the existing categories used for male prisoners. According to contemporary accounts, the doctor noted her complaints, but found no clear reference in camp medical guidelines for how to proceed. The issue was not urgency alone. It was classification. Was this a condition requiring hospitalization, exemption from labor, or merely observation? Each option carried administrative consequences that required justification. Camp medical services operated under constant pressure. In most facilities, doctors were responsible not only for treatment, but for maintaining labor output. Their reports directly influenced work assignments and ration allocations. Exempting a prisoner from labor required documentation and often approval from camp command. In this environment, uncertainty was a problem. The female prisoner's condition did not align with the standardized diagnostic shortcuts doctors relied on to manage overcrowded infirmaries. Witnesses later recalled that the doctor consulted existing medical manuals and corresponded briefly with superiors. According to camp correspondence, he asked whether special provisions applied in this case. The reply, preserved in fragmentary form, offered no detailed guidance. It reiterated general obligations to provide care, but left implementation to local judgment. This response reflected a broader pattern. Higher authorities acknowledged the issue without providing new rules, effectively shifting responsibility downward. As a result, the doctor improvised. According to medical logs, the prisoner was temporarily reassigned from labor and placed under observation in a corner of the infirmary. This was not a formal ward, but a repurposed space, separated by screens from male patients. The arrangement was practical rather than policy-driven. It allowed monitoring without disrupting the camp's overall routine. At the same time, it highlighted how the existing system bent rather than adapted. The prisoner herself remained largely silent in the records. There are no personal statements attributed to her, no descriptions of her thoughts or reactions. What can be reconstructed comes from administrative notes and later testimony by other prisoners. Contemporary accounts indicate she complied with instructions, attended examinations, and returned to assigned quarters when directed. Her experience was shaped less by individual interaction and more by institutional uncertainty. Medical care in prisoner of war camps was never solely a clinical matter. It was deeply intertwined with discipline and control. Camp doctors were officers or supervised professionals operating within a military hierarchy. Their authority extended only as far as regulations allowed. In cases where those regulations were incomplete, discretion existed but was limited by fear of scrutiny. Deviating too far from established practice could invite accusations of favoritism or mismanagement. This tension was particularly evident in cases involving women. The camp medical infrastructure lacked not only equipment, but conceptual categories for addressing female-specific health issues. According to post-war medical reviews, many camp doctors acknowledged that they had been unprepared for such cases. Training emphasized battlefield trauma and mass disease management, not individualized care in prolonged detention. In this camp, the doctor's solution remained provisional. After several weeks, according to records, the prisoner was returned to modified duties rather than full labor. The decision was justified in medical terms, but framed administratively as a temporary adjustment. No permanent change to camp policy followed. The case was treated as exceptional rather than instructive. Similar situations occurred elsewhere. In Allied-run camps holding Axis female auxiliaries, medical officers encountered parallel challenges. Contemporary accounts indicate that while conditions were generally better, the same lack of clear guidelines persisted. Female prisoners were examined, treated, and monitored within systems designed for men. Where complications arose, doctors relied on personal judgment rather than institutional support. The broader issue was not negligence but structural design. Prisoner of war camps were built to manage large populations efficiently, not to accommodate diversity. Medical rules were optimized for speed, predictability, and minimal deviation. When doctors faced cases that did not fit, they were forced into a narrow space between professional responsibility and administrative compliance. The female prisoner's case eventually stabilized, according to available records. There is no indication of dramatic deterioration or resolution. The file simply ends with routine entries, indistinguishable from dozens of others. This absence of narrative closure is itself revealing. The system absorbed the anomaly without recording its implications. For historians, such cases are significant not because of what happened to a single individual, but because of what they reveal about wartime institutions. Medical systems in camps reflected broader assumptions about who soldiers were and what their bodies required. Women, though present in increasing numbers during the war, remained peripheral in planning and regulation. According to camp reports from multiple theaters, administrators rarely revised procedures in response to isolated cases. Instead, they relied on temporary fixes that preserved overall structure. Doctors were expected to manage uncertainty quietly, without drawing attention to gaps in the rules. This approach maintained order, but postponed reform. The war ended before these issues could be fully addressed within the camp system itself. It was only in the post-war period, during reviews of detention practices and revisions to international law, that the limitations became formally acknowledged. Medical officers who testified after the war often described their wartime decisions as improvised responses to situations for which they had no guidance. Looking back, the case of a doctor facing a medical situation the camp rules did not fully cover illustrates a central feature of the Second World War. It was a conflict fought not only on battlefields but within systems stretched beyond their original design. Camps, clinics, and administrative offices became sites where assumptions were tested by reality. The female prisoner did not change the system on her own. There was no immediate reform, no directive issued in response to her case. But her presence exposed the distance between regulation and experience. Doctors confronted that distance daily, making small adjustments that allowed the machinery of detention to continue operating. In examining such moments, historians are reminded that wartime systems often appear coherent only in retrospect. At the ground level, they were maintained through improvisation and compromise. When doctors faced cases the rules did not fully cover, their responses reveal both the strength and the fragility of institutional order during the war.